Okay, thank you everyone for joining us, and welcome to the Cancer Research Institute's webinar series, Breakthroughs in Cancer Immunotherapy. Today's date is Wednesday, June 10th, 2015. The title for today's webinar is Oncologist-to-Oncologist, How to Treat Your Patients with Immunotherapy. In this webinar for oncologists and healthcare professionals, our expert speaker will discuss what cancer immunotherapy is, what it is like to treat patients with immune-based medicines, and how to handle side effects. You can tweet your comments throughout the entire webinar, or you can follow along on live tweeting at Cancer Research and using the hashtag CRIWebinar. My name is Brian Brewer, and I'm Director of Marketing and Communications for the Cancer Research Institute. Cancer Research Institute is the world's only nonprofit organization dedicated exclusively to harnessing the immune system's power to conquer all forms of cancer. We fund scientists all around the world whose work has led to significant breakthroughs in treating cancer with immunotherapy. After a 25-minute presentation from our speaker, we will open the discussion to questions submitted by you. You can pose your questions at any time by typing in the Q&A box on your screen. Today's webinar is being recorded and will be made available for viewing on the Cancer Research Institute website. Now it's my pleasure to welcome today's speaker. Dr. Michael Postow is a board-certified medical oncologist and part of the Melanoma and Immunotherapeutics Service at Memorial Sloan Kettering Cancer Center. He has an interest in developing clinical trials for patients with melanoma involving immunotherapeutic strategies. Dr. Postow received his MD from New York University School of Medicine and completed his residency at Brigham and Women's Hospital, Harvard Medical School, and his fellowship in medical oncology at Memorial Sloan Kettering Cancer Center, where he served as chief fellow. He is the author of Pocket Oncology, a handbook on all aspects of oncology care. Welcome, Dr. Postow.
Well, thank you very much, Brian. I really appreciate the opportunity to speak to everybody about a very exciting topic. And today's topic will be called Putting Cancer in Check with Immunotherapy, Melanoma and Beyond. This is a slide showing my disclosures. So in 2013, the medical journal Science deemed cancer immunotherapy as the scientific breakthrough of the year. And this is a picture showing a cancer being destroyed by a T cell, which is part of the immune system. So out of all the scientific advances in 2013, cancer immunotherapy was deemed to be the most important scientific breakthrough. But the cancer immunotherapy story didn't begin in 2013 with this major breakthrough. It really began in 1891. And this picture shows James Naismith, who invented basketball. And 1891 was the same year that basketball was invented, and this is a picture of him with his famous peach basket. But also in that same year, 1891, this gentleman, William Coley, invented immunotherapy for cancer. He essentially found that patients that were treated for tumors with surgery that then developed infections after the surgery had spontaneous regressions of their tumor. So that even though they had a bad infection after their cancer surgery, they had spontaneous regressions of their tumor. And it was believed to be from immune system activation due to this infection that then led to these spontaneous tumor regressions. And this is a picture from him from the 1890s. And this is a picture of a patient that he treated with sarcoma that had surgery and had spontaneous regression of a tumor involving his neck right in this particular area here, shown by the green area. So this was something that began in 1891 with cancer immune therapy, the exact same year that basketball was invented. So what do we know about how the immune system can treat cancer? What have we learned from the clinical experience in melanoma since the 1890s? And how can we improve? And this is a treatment modality that's important for patients with melanoma because we now have FDA-approved treatments in melanoma, but we also have FDA-approved treatments in other cancers as well. And these treatments are likely to become important treatments for patients with many different kinds of cancers, not just melanoma. So when we think about using the immune system to treat patients with cancer, it's essentially as simple as a T cell, as shown here in this orange diagram here with the cytotoxic T cell killing a cancer cell, shown here in red. So the cytotoxic T cells come to the tumor, destroy the cancer cell, and then the tumors regress. And that is the point of all of this cancer immunotherapy. And so there have been many strategies that have been in play to try to enhance the T cell's ability to kill these cancer cells. And we know, unfortunately, not every patient will have the reduction of their cancer cells by this T cell-based immunotherapy approach, but we're trying with many different agents and different strategies to increase the number of patients who benefit. So this is a bit of a slide showing how the immune system and cancer treatment can interact and work together. What happens with the normal immune system reaction against cancer is that you'll have a tumor, as shown here in this gray area on the bottom left of the slide. The tumor releases these tumor antigens, which are little peptides or portions of a protein that are released in response to tumor damage, or sometimes the tumors may just release them on their own. These are picked up by specialized cells called antigen processing or presenting cells, like dendritic cells, and processed, and these antigens are brought to lymph nodes that can sometimes swell, like when the body's having a swollen lymph nodes from a viral infection. And in the lymph nodes, these antigen presenting cells show these proteins, these antigenic peptides, to the T cells, which, as I mentioned before, go to the tumors and destroy the cancers. And so each step along the way of this cycle of bringing in more tumor antigens through vaccination, or enhancing the ability of these antigen presenting cells to present antigens to the T cells in the lymph nodes, or to keep the lymph nodes and the T cells fighting the tumors a bit harder to destroy the cancer. Those are all strategies that have been tested in various immune therapy approaches through the years since the 1890s when this was first invented. But what we know is sometimes cancer and the immune system are in a bit of a push and pull, or a bit of a wrestling match. And as we think about it, sometimes in patients with cancer, this big wrestler here is the tumor. And no matter how hard the immune system is pushing against this tumor to try to push it over, the tumor is just not wielding to this pressure of the immune system. So what our immune system strategies are trying to do is that we're trying to take the immune system shown here and flip this equation so that this big wrestler can be the immune system and this little guy would be the cancer. And so what are the ways that we can do to enhance the immune system's ability to destroy the cancer cells? And that's what we'll be talking about through the course of this presentation. There will be four main strategies that we'll talk about, and I'll touch upon the first few briefly with a focus on the last. The first one is vaccine treatment. The second would be cytokine treatment. The third would be adoptive cell transfer. And the fourth are immunomodulatory antibodies. And each of these work at a different stage along this immune system cascade with the same goal of getting a T cell to kill a cancer cell. And we want the immune system to be that big wrestler and that little person to be the cancer so that we can destroy the cancers. So what have we done in the past and what has been successful in each of these four realms of immunotherapy? Vaccines, cytokines, adoptive cell transfer, and immunomodulatory antibodies. With vaccines, there have been a number of vaccines that have been tested. The one currently that's FDA approved is this drug called Sipuleucel-T, which is a vaccine for men with castrate-resistant prostate cancer. This is to show that patients that receive this particular vaccine with prostate cancer compared to those that did not receive this vaccine, those that had the vaccine had improved overall survival compared to those that got the placebo treatment in this trial. So this is just proof that vaccines can be helpful in certain disease contexts. Unfortunately, not all, and unfortunately, not all cancers have been shown to be responsive to these vaccine approaches. But at least in this example with men with prostate cancer, this particular vaccine has been successful and is FDA approved. Cytokine therapy, or the second type of immune therapy strategy that we'll be talking about, was tested with this drug called high-dose interleukin-2, or IL-2, as shown here. And this really established the principle that a group of patients with advanced cancers, particularly those with metastatic melanoma, shown here on the left, and metastatic kidney cell cancer, or renal cell carcinoma, as shown here on the right, in a small group of patients treated with interleukin-2, the possibility for durable long-term cancer control can be achieved. And that's shown here on these curves, that patients that had a complete response, as shown by this red line, complete response to interleukin-2, can have their cancer remain under control for many, many, many years. Now, unfortunately, this percent of patients that benefit from this is lower than we would like. We wish this was 100% of patients. But it again established the principle that cytokines like interleukin-2 can be used to help treat patients with kidney cancer and melanoma, and that in a select group of patients, they can have very long-term benefits to some of these treatments. So certainly something that we need to improve upon, but very promising. The third type of treatment, called adoptive cell transfer here, is essentially taking T cells themselves and transferring them into the patient directly. And many of us have heard about chimeric antigen receptor T cells, or CAR T cells. That's one form of adoptive cell therapy. Other of us have heard about something called tumor infiltrating lymphocyte therapy, and that's where tumors are resected from patients and lymphocytes are taken out of those tumors and engineered in particular ways such that they can be given back to patients. And when patients get these T cells directly in them, or tumor-fighting T cells, those T cells can destroy melanoma and other cancers as well. It's a bit of a complicated procedure to go through this because it often requires surgery and time when the T cells are treated in the laboratory, but something that is certainly of interest and promising. The fourth category of immune therapy that we'll be talking about is immunomodulatory antibody use, or some of the new checkpoint inhibitors for the immune system, and that's beyond the vaccine, cytokines, and adoptive cell transfer. That's the fourth type of strategy that we'll be talking about. And so when we think about antibody drug treatments that target the T cells directly, we again just need to remember the main principle of cancer immunotherapy: to take a T cell and kill a tumor. If you remember in the very beginning of this talk, the slide showing the T cell killing the tumor, that is all that needs to happen. So we know that T cells can get turned on by many signals here. You don't need to remember all the details of these letters and numbers, but the principle is that T cells can be turned on by activating signals, and they can be turned off by inactivating signals. So to turn on the T cells more, we need to do one of two things: turn on the T cell activating signal, or turn off the inactivating signal. So if we turn on the activating signal, it turns on the T cell more, or if we turn off the turn off signal, it will turn on the T cell more. So this is equivalent to hitting the gas pedal. On this side, it's equivalent to taking off the brake on a car. And we'll be focusing the discussion today on two targets: cytotoxic T lymphocyte antigen 4, or CTLA-4, and programmed death 1, or PD-1. These two turn-off signals here have targets that are made at the current time by FDA-approved antibodies that block these two targets, and we'll be going through those in more depth throughout the rest of this talk. Essentially, these are ways of turning on the T cell by turning off these particular brakes. Cytotoxic T lymphocyte antigen 4, or CTLA-4, is involved when a T cell is stimulated by a dendritic cell. If you remember in the beginning, I told you that dendritic cells take these antigenic peptides to the T cell and show these peptides to T cells via the T cell receptor shown here. But that by itself is not enough to turn on the T cell, as shown by these positive signs here. It actually also requires a second signal to turn on the T cell. And the combination of this antigenic peptide with the T cell receptor and the second signal through B7 and CD28, that is what's required to turn on the T cell. And cytotoxic T lymphocyte antigen 4, or CTLA-4, is then expressed on the cell surface, and it essentially keeps the T cells in normal harmony from being too overly active, and it's a negative signal for CTLA-4. So this is a seesaw of activity. We want it to be turned on in certain contexts, but importantly for normal immune system function, you want it to be turned off in other contexts. And that's where CTLA-4 comes in. And so what we know in patients with cancer is that we want the T cells to fight the tumors stronger. So the antibody treatments have been developed to block CTLA-4, and that's exactly how they work. PD-1, the other checkpoint that we'll talk about today, is also involved in the T cell activation stage, and I won't go through the complexities of the mechanisms here, but essentially it functions in some similar ways to CTLA-4. But also importantly, PD-1 functions when the T cells come to kill a tumor. The tumors express a molecule called Pdl1, and Pdl1 and PD-1 can interact, and this turns off the T cell when it's trying to kill the tumor. We don't want the T cell to be turned off when it's trying to kill the tumor, so we don't want this Pdl1 molecule here shown on the tumor to interact with PD-1 on the T cell. So we have antibodies that have been developed, drugs that disable this interaction here between PD-1 and Pdl1, and here again, shown here, same interaction as well, to help these T cells kill these tumors better. So that's another important immune checkpoint. And when you put them all together in the immune system, you think about the antigen-presenting cell activating the T cell, and that's where CTLA-4 inhibits the normal T cell function. And then the T cells go through the bloodstream, go into the tumor to destroy the tumor, and that's where PD-1 and Pdl1 plays most of its role. So we have strategies to prevent this negative signal early in the immune system, and we have this PD-1, Pdl1 strategy to prevent the immune system from being turned off late in the immune system. So what do we see when we give these drugs? So I'll start with one of the issues is that, unfortunately, these are very important molecules in normal immune system function, and these drugs can cause side effects. Because these signals normally turn off the immune system, when we block them with treatments that turn on the immune system, there can be some type of immune-mediated side effects, such as rash, diarrhea, liver inflammation, and problems with the hormone system. Now, with CTLA-4 drugs like ipilimumab, the majority of the patients get through without any significant side effect, at least 3/4 of the patients. There are a group of patients that have more of a moderate side effect. Most of these patients that get these side effects do have complete resolution of these side effects with steroids or other immune suppressant drugs. But that is something that needs to be considered when patients are getting treatment with this CTLA-4 blocking antibodies. PD-1 and Pdl1 has also similar side effects as these. However, there are some other ones that can be seen, like arthralgias or achy joints and fatigue and rash. The degree of significant side effects with PD-1, Pdl1 antibodies is less than with CTLA-4 blocking antibodies. But what's important is when we consider these different treatment approaches with these T-cell-based therapies that turn on the T cell by turning off these negative signals, they're not any worse necessarily than standard chemotherapy, which in some cases can cause hair loss, alopecia, nausea, myelosuppression, or bone marrow suppression. So side effects with these treatments are different, not necessarily worse. So here are some pictures of some rashes that were seen in a patient that was treated with ipilimumab, and this is just a very faint rash on the arms and chest. This is not usually a rash that happens on the face, fortunately. These can be treated successfully with topical corticosteroids like hydrocortisone cream or triamcinolone cream if this occurs. This is a picture of a colonoscopy in a patient that had diarrhea, showing there can be some inflammation of the bowel. And any patients that you have that are having inflammation of the bowel or diarrhea need to be treated with steroids or other immunosuppressants to make sure that this doesn't become too problematic. This was a biopsy of this patient and showing a lot of the lymphocytes in the colon as well. So this turns on the immune system not just against melanoma and other cancers, but also against normal healthy tissue in certain contexts. The endocrine system can also be affected by this drug, and this is a patient's pituitary gland as shown here on a brain MRI. And in June of 2004, this patient was then treated with ipilimumab, and over time, this was 6 months later, this patient developed swelling, shown here where this green arrow is, swelling of the pituitary gland, and this patient had some headaches and fatigue, and this patient was diagnosed with something called hypophysitis. So anything ending in itis is an inflammation. Hypophysitis is a word referring to pituitary inflammation that can happen as a result of this drug and the immune system being activated And this can also be successfully treated with steroids. Sometimes patients that have this need to be supplemented with an extra hormone, like extra steroid hormone or thyroid hormone if they need it. The lung can also be inflamed by some of these drugs. This is a syndrome called pneumonitis, which is inflammation of the lung. And this is a patient's CAT scan shown in February 2011 with melanoma that was treated with a few doses of ipilimumab and then a few doses of the Pdl1 drug nivolumab. And this is showing some lung inflammation that happened. And this patient had some shortness of breath. But this was completely reversible with steroid immune suppression over a couple of weeks. And so the bottom line is that most of these side effects, if they occur, they can be reversed with particular immunosuppression, and generally prompt recognition and awareness of the side effects is most important for optimizing outcomes. Unlike chemotherapy, where side effects can happen often in predictable time courses, several days later, patients may feel tired. About 10 to 14 days later, with chemotherapy, the blood counts may go down. That's different with some of these drugs where the side effect incidence occurs weeks to, in many cases, even months after treatment initiation. This is to show the peak of some of these side effects, as shown here on the right, happen at least a month into treatment, and even some peaking into about 2 months into treatment. Some can even happen much longer term, even after stopping treatment, but most happen within the first few months, not in the first few days. If you're wondering what to do with the patient that has a side effect, just even Googling something as simple as ipilimumab management or going to Bing, as shown here, will bring up what's called the risk evaluation and mitigation strategy, where if you click on this in Google or Bing, it'll bring up different algorithms. This one's an example for diarrhea and colitis, to show if a patient is experiencing certain side effects as shown here, what the particular management should be and what the follow-up should be. So it's very algorithm-based treatment, and this has all been hammered out from prior experience with all of these agents. And this is applicable to melanoma patients, but also patients with many other malignancies as well. So as a reminder, we've been talking about blocking CTLA-4 early in the immune system and PD-1 at the end of the immune system. And at the bottom of the slide show all the different names of all the various drugs that have been used in these particular contexts. And to dive into the details on the efficacy of CTLA-4 blockade with ipilimumab and tremelimumab. So we were speaking about the two CTLA-4 blocking antibodies, ipilimumab and tremelimumab. And ipilimumab is the one that was FDA approved for patients with melanoma, and tremelimumab has been tested in clinical trials as well. So this is a slide showing the efficacy of patients that were treated with melanoma with ipilimumab, showing that patients that received ipilimumab had improved overall survival compared to those that received the vaccine in this particular study. And it shows that there are patients that we still need to do better with, in that we wish this was 100% effective for all patients, but our hope is with additional treatments that we can eventually improve the response rate of patients with melanoma treated with ipilimumab and improve the survival further. And on the next slide, what it shows is that patients that were treated with ipilimumab can have a very long-term survival if they're one of the patients that responds well to ipilimumab. And so while it is hopeful that we can have a 100% response rate with ipilimumab, there are a group of patients that can have this long-term benefit with ipilimumab with stable cancer control, and then we can try to see if we can get this to 100%. But that is something that we absolutely need to try to improve upon. But there's a group of these patients that can have this long-term benefit. So the long-term results of these studies have shown that this benefit of ipilimumab lasts for a long time in certain patients. And this is shown up to 5 years of follow-up now, that essentially ipilimumab doubles the chance of patients having long-term survival. And therefore, it is our hope, again, that we can build upon the success of ipilimumab in the long run. And again, we want this to be 100% of patients that benefit, but in a lucky group of patients, this drug can work for many, many years. And it appears that patients that have several years of benefit to this drug can continue to have this benefit for many subsequent years. We know that ipilimumab responses can be different from standard chemotherapy in that some patients can have an initial apparent disease progression, as shown here. This is a patient who was treated, this is their liver before they started, and after ipilimumab treatment, it looked like some of the tumors in the liver were actually getting worse. But over time, the liver actually improved with ongoing treatment. So even though this patient had worsening initially with their tumors, with just waiting and a little bit longer, this patient ended up ultimately having a benefit with the treatment. And so therefore, it's unclear why this exactly happens. Some people think it might just be that the immune system takes some time to be activated in these patients and that this is the cancer growing before it ultimately gets better. And other people say, well, maybe this that makes it look worse is just the immune system reacting against the melanoma. Maybe it's not just the tumors getting worse, it's just the immune system and the tumors in that fight that we were talking about. So we have a whole new way of thinking about looking at scans in people that are having these immune treatments. We know that we have a whole new response criteria evaluation in clinical trials for these agents, and we're trying to see if that's the appropriate way of looking at patients. But the principle for managing patients is if you have a patient that has asymptomatic evidence of slight worsening on a CAT scan of some areas of melanoma, that may not be that the drug has not worked. It might just be that the immune system is taking longer to activate in that particular patient, or maybe something looks bigger on a CAT scan, but may not necessarily be bigger. And therefore, just waiting and repeating scans in certain patients that are asymptomatic is certainly worthwhile in certain contexts. Now, unfortunately, most patients that have obvious progression with new lesions or very much enlarging melanoma lesions, that is someone that we should think about for a different treatment. But for people that have asymptomatic or low changes, then this is something that we can consider to repeat the scan without changing treatments immediately. So as we now move to the second immune point, the last checkpoint that we'll be talking about in this talk, which is the Pdl1 checkpoint, is shown here. Or shown here again, if just as a reminder, when the T cells come and destroy the tumor, the Pdl1 pathway blocks the immune checkpoints at this particular point. There have been a number of drugs in clinical trials and now FDA approved for patients with melanoma and other malignancies as well. One of the drugs, nivolumab, has been approved for patients with melanoma and non-small cell lung cancer. Another one called Pembrolizumab has been approved for patients with melanoma. And this table just shows a whole bunch of them that have been in clinical trials. And it's hoped that a number of these other targets and other PD-1 or Pdl1 antibodies will become FDA approved as time progresses. So this is to show patients with melanoma that were treated with nivolumab. This is a spider plot, so patients are on the measured as a line here, and each of these patients was followed over time, and on the y-axis it shows their tumor burden, and it shows that many patients had shrinkage of their melanoma when they were treated with this PD-1 antibody, and that these patients that had tumor shrinkage remained shrunk for a long time in certain contexts. And this is to show some patients, even with this drug, nivolumab, had growth followed by ultimate shrinkage, just like we saw with that patient in the liver who had apparent worsening in the liver that was treated with ipilimumab. And we know that nivolumab in many contexts is actually better than chemotherapy. This is a study in patients with melanoma where the PD-1 antibody nivolumab improved overall survival compared to patients treated with dacarbazine. And you can see these patients that were treated with melanoma really had excellent long-term survival compared to the patients that were treated with chemotherapy. And therefore, this drug nivolumab is now approved for patients with melanoma. And similar data have been shown with this PD-1 antibody called pembrolizumab. This one has been approved for patients with melanoma, and it's our hope that over time, additional approvals in other diseases will be seen as well, like lung cancer and other malignancies. And this is a patient that had a very big tumor around the heart and in the left part of the lung cavity and a big liver tumor. And this patient had had prior chemotherapy, interleukin-2, and ipilimumab. And this patient, a year later, shown here on this CAT scan, had essentially near complete disappearance of their tumor here in the left chest cavity and around the heart, and also the liver substantially improved as well. And so this is another and very important PD-1 antibody called pembrolizumab It appears to be similarly effective to ipilimumab. And again, there's just no real differences in efficacy or side effects between pembrolizumab and ipilimumab. But when we compare the new PD-1 antibodies to ipilimumab, these are just very, very new data that it looks like the PD-1 antibodies like pembrolizumab is even better than ipilimumab. Now we know, as we were talking about a few slides ago, that ipilimumab can result in very long-term tumor control for many, many, many years in a group of patients, lucky patients. And ipilimumab is a very important drug for those patients that have received it and have had the benefits. But the PD-1 antibodies like pembrolizumab and nivolumab have been more recently demonstrating superiority over ipilimumab. And if you have a patient that you're deciding what to treat with first at this point, we now have some updated data that suggests pembrolizumab or nivolumab may even be a good choice, even instead of ipilimumab, at least by itself. So we're still trying to work out these data, and the long-term follow-up for the PD-1 data are not yet as mature as ipilimumab, but it's our hope, of course, that we continue to improve upon prior treatments. So when we think about where has the efficacy been seen with PD-1 and Pdl1 drugs, the details of this table are not necessary to remember, but what's key to think about is we've seen this in melanoma, as shown here. But what's important is that we've seen this in many solid tumors now, including non-small cell lung cancer and kidney cancer, ovarian cancer, head and neck cancer, many different cancers, hematologic cancers, including Hodgkin lymphoma. So the bottom line is, even when you black out melanoma as a traditional immune therapy responsive to immune therapies, or the traditional cancer responsive to immune therapies, there have been a number of other tumor types that have been shown to be effective with the exact same drugs that have been used in melanoma patients. So this is not something that's limited to melanoma. This is used for patients with many other kinds of cancers as well. And the same is true for the Pdl1 antibodies shown here. And if you take out melanoma, you can see that there are many, many tumor types that are being investigated in many different contexts with Pdl1 antibodies. And these are just to show you that there's significant activity in this area of all these different treatments across the spectrum of all of oncology. This is a picture of a patient with head and neck cancer. You can see here she's 96 years old. She had prior treatment for this head and neck cancer and this big tumor here on the left part of her neck. And after treatment with a Pdl1 drug, this substantially improved. And this is a picture that was shown at ASCO, or the American Society of Clinical Oncology meeting from 2014. And she derived a very incredible benefit from this. And just a testament to the fact that other cancers are demonstrating some benefit from these treatments as well. This is a spider plot from showing patients with bladder cancer that had substantial regressions with the Pdl1 antibody shown here. And these are patients, again, on the spider plot, and any line going down is showing a patient that had benefit. And these green lines are patients that had partial responses, and they seem to be lasting for quite a long time in these studies. And our hope is that these last for a very long time. And with more follow-up, we'll certainly know how long these types of things last. We know that treatments like PD-1, such as pembrolizumab, can have side effects similar to ipilimumab. This is a treatment that's associated with a relatively low rate of significant side effects. In this particular study, 17%. But put the other way, I like to tell patients that 80 to 90% sure that they're going to get through treatment without a significant side effect, at least with the PD-1 antibodies, and that appears better than ipilimumab. So ideally, we wish we knew who had a benefit to immune therapy and who didn't have a benefit for immune therapy, so we could pick patients that were likely to benefit from immune therapy and unlikely to treat patients that wouldn't have a benefit. So if we knew we had something at the beginning that said, Mr. Jones, this drug will work for you, we're going to use this drug, or maybe it won't work for you for this reason, we're going to pick a different drug, that would certainly help with minimizing toxicities from these treatments, and certainly it would be something that we would want to think about in terms of optimizing treatment in a personalized nature. But at this point, we don't unfortunately have anything that's perfect just quite yet in terms of being able to pick out patients who benefit. And this is a plot showing Pdl1 expression, because Pdl1 expression or if we remember from the slides earlier, that protein on the T cells has been investigated as a potential biomarker for patients treated with PD-1 antibodies. And this is showing a tumor that was removed from a patient, that patients can be characterized as Pdl1 negative, where Pdl1 has not been shown to be in the tumor, or very low expression in the tumor, as shown by this brown staining here, or Pdl1 positive, shown by very high expression, or a lot of this brown material here. So there are some questions about, well, where do we call patients negative and where do we call patients positive? If there's really a continuum of expression and a continuum of positivity. But the bottom line is this biomarker cannot be used at the moment to decide if a treatment is appropriate for a patient or not, but it is being investigated in clinical trials. And so why can't it be used for selecting this treatment for patients? Well, we know that patients that have received nivolumab in clinical trials, there's been improved survival for patients that have gotten this drug nivolumab, even if they haven't had the Pdl1 biomarker. So if patients are positive for the biomarker and if they're negative for the biomarker, it doesn't seem to matter. These drugs like nivolumab and drugs like pembrolizumab can benefit both of them compared to chemotherapy or other control arms in trials. Now, it does seem to suggest, with whatever I just mentioned, it does still seem to suggest this biomarker is important, though, because patients that are positive for the biomarker may even have more benefits than those that are negative. However, patients that don't have the biomarker should still be offered opportunity to participate in clinical trials with these approaches because they still can absolutely benefit from these drugs. But what we need to try to do is to understand how do we make more people Pdl1 positive, and what should we maybe consider for patients that are Pdl1 negative that can still benefit from these drugs, but might not have as much likelihood as benefiting from patients that are Pdl1 positive. And so unlike other biomarkers in oncology, like the EGFR mutation in lung cancer that's used to help pick out treatments like erlotinib for patients, or the BRAF mutation in melanoma, which is used for patients to pick out BRAF-directed treatment like vemurafenib or dabrafenib, or HER2 in breast cancer patients with treatments like trastuzumab. So there are a number of these other biomarkers that can be used to pick out treatment. Pdl1 at this moment is not being used for treatment selection for patients with PD-1 or Pdl1 approaches, but in the future with more research, we hope that these types of things can ultimately be helpful. Different assays measure Pdl1 differently, so we cannot be certain that what we're doing in terms of the technology of the tests is perfect across the different technologic platforms using it. As I mentioned before, Pdl1 negative tumors can still respond. Pdl1 is a dynamic marker, so sometimes patients may be negative at one point and then may be positive at another point, and this is not something that's the same all the time. And then in each individual patient, there can be substantial heterogeneity. So sometimes some patients might have tumors that are positive and sometimes tumors that are negative. And so I don't think at this point we have a pre-treatment immune system biomarker that we can be used to select a treatment for a particular patient. So at the moment, I call it putting a square peg into a round hole. It's not perfect where we have a round peg and a round hole. These things don't fit perfectly. We have, if we think about what we're trying to do, if we think about this being the tumor here, we have the ability with the immune system to modulate the tumor to make this a square hole so we can fit the drug with the square hole by making the tumor more immunogenic through possibly doing other combinatorial treatments, or maybe using radiation or chemo to make the tumor more immunogenic, and then using immunotherapy. Or perhaps we have the ability using the immune system to modulate the immune system so that it could fit with a particular patient's tumor. And so this is a little bit different than a method of finding a mutation and treating with the drug. Pdl1 or other immune system biomarkers at this moment are not yet ready for treatment selection. It's an active area of research. We're trying to use combination treatment to increase the number of patients who benefit, or take that tumor, as I showed on the other slide, as shown by that round hole, and make it more adaptable to being manipulated by the immune system. And there have been a number of strategies that have been used, such as chemotherapy, other anti-angiogenic agents, hormonal treatments, targeted therapies, other immune therapies, and radiation. And all of these have been in clinical trials to test to see if combinatorial therapy can help compared to single agent immune therapy. And none of these has been proven better than single agent therapy as of yet, but we're certainly very interested in these combinations. And this is just an example showing one of the promising studies recently that was presented and published of the combination of ipilimumab in combination with nivolumab, showing that this combination of drugs, ipilimumab and nivolumab, or blocking CTLA-4 with ipilimumab and Pd1 with nivolumab, is better than ipilimumab by itself. And so this is just a waterfall plot showing all the patients that had the benefit with this combination, and certainly the percent chance of having a benefit with the combination is higher than ipilimumab alone. And so at this moment, with new patients, at least with melanoma, for new patients that haven't been treated yet, we're moving away from ipilimumab and using combinatorial therapy with either nivolumab and ipilimumab or other approaches. And we're still trying to see if this combination is better than nivolumab alone or better than pembrolizumab. We don't yet know that, but again, the power of potential with combination therapy for certain patients. So to summarize, what we've learned with the manipulation of the immune system in these patients is that melanoma and other cancers can absolutely be controlled with immune therapy approaches. We've seen that with the CTLA-4 blocking antibody ipilimumab, helping a subset of patients for a very long time. We've seen that with PD-1 approaches in many different cancers. We've seen that with some of the other approaches I mentioned at the beginning of the talk, like vaccine therapy, adoptive self-treatment, and cytokine therapy. We have biomarkers like Pdl1 and other markers of the immune system that we're investigating to see if they can help patients with melanoma and other cancers. But we don't yet know if these biomarkers can be used for treatment selection for particular patients. We certainly don't have anything for clinical management at this time. Our hope is that over time we can get there, and it just requires substantial more research. We have some promising evidence of combination therapy like ipilimumab and nivolumab that's been shown in phase 3 studies now. It's recently presented at the American Society of Clinical Oncology meeting just about a week and a half ago. But we don't yet really know if it's better to combine all these agents or perhaps give them in some particular sequence, perhaps driven by a biomarker, to help the maximum number of patients. And with that, I would just like to close my section of the talk. It was an honor to speak with you on this web program today. I thank you for bearing with us during the technical learn about cancer immunotherapy in melanoma and beyond. And I think the beginning is just here, and there's more to come in the coming years with this topic. And I'll look forward to taking your questions. Thank you again. From 1891 to 2015.
Thanks very much, Dr. Postow. And I know for sure that we're all hoping that immunotherapy will be a slam dunk in the treatment of cancer. So I very much appreciate the placement of the start of immunotherapy with the creation of basketball. So we do have a few questions related to your talk. And the first one is, can oncologists in local or community centers feel confident in treating patients with checkpoint inhibitors and managing their effects? Or is it better to refer a patient to a cancer center?
So that's a great question about where should these treatments be given. So I think with the expanse of these immune checkpoint blocking antibodies like the PD-1 approaches such as pembrolizumab and nivolumab, everyone is going to need to learn how to use these agents across the spectrum at academic centers, community centers. These drugs will be approved, and they're already approved in non-small cell lung cancer. So many different patients, many different malignancies will be treated with these. I think these need to be learned by all oncologists across the spectrum. PD-1 approaches, particularly with nivolumab and pembrolizumab, are relatively easy to give because the rate of significant side effects is very low, about 10 or 15% in many studies. And those can be appropriately managed by steroids and following those algorithms, as I showed on the web where they're available. And I think these treatments should be given by any doctor anywhere, and it's going to require a learning curve, but it's something that we're all going to need to learn. So while patients may benefit from a referral to an academic center at a particular time point just to help check in every now and then to make sure there's no clinical trial or other opportunity for them. I think this is something community oncologists absolutely should be able to do and will need to do as well.
Are there other members of a hospital staff, for instance, perhaps immunologists, that an oncologist could consult with before treating a patient with immunotherapy?
So treating patients with immunotherapy is certainly a multidisciplinary approach where nursing staff is very important to the care of these patients and communicating with side effects and being on the phones with patients and working with them. I do think sometimes it's worthwhile for patients that are being cared for by oncologists that may have much experience with chemotherapy and targeted therapies, but perhaps less so with these immune therapies, where a referral to a larger center, perhaps an academic center where there may be some more experience in particular niches where people have been treated with these antibodies, just even for a one-time visit may be worthwhile so that patients can then have the opportunity to not only meet with that doctor, but also that doctors have a point of contact to work together with some of these patients. And often those patients can be mutually discussed between doctors at academic centers and community centers, and experience with these and expertise with these agents can be shared between those treating institutions.
So at what point does a patient need to, or should a patient consider treatment with an immunotherapy? So we've seen some checkpoints approved as frontline therapies, but in tumors other than melanoma, for instance, at what point in a patient's treatment journey should an oncologist suggest perhaps that the patient consider immunotherapy?
So every patient should be, immunotherapy has a different role in each different disease. So it depends on the specific kind of cancer that the patient has and where they are with their disease. In melanoma, immunotherapy is certainly something to be considered as the first treatment for patients, particularly those that don't have a BRAF mutation. In my opinion, immunotherapy is clearly the first treatment that should be given in those patients. In other diseases, it's a bit different. So immunotherapy is not the first treatment for many cancers that are relatively have a high percentage of cure with combination chemotherapy. So for example, Hodgkin lymphoma with combination chemotherapy, early stage Hodgkin lymphoma can be very effectively treated and in many cases cured. And immunotherapy would not be an appropriate first treatment choice in that particular patient, but perhaps a clinical trial combining chemotherapy and immune therapy, or perhaps if other standard treatments like chemotherapy in certain diseases has not been effective, that's when immunotherapy may be able to be considered. And so each different kind of cancer is different for when this should be considered. For melanoma, certainly the first treatment I would tell patients they should be considering would be immune therapy, but for other cancers that may not be the case.
Okay. And you mentioned that sometimes the response patterns to immunotherapy are different from what most oncologists have seen when treating patients with conventional therapies like chemotherapy or radiation, where you see a very dramatic tumor regression at the outset, and that's how you know it's working, versus with immunotherapy, there may be delayed time to response. There may be apparent new growth of tumors or new lesions or growth of existing tumors. So knowing that that's a common pattern that we see when treating patients, how does a doctor know? Are there other signs or indications that would let a doctor know that an immunotherapy might be working for the patient?
It's a really tough question because there is a great need in terms of our ability to know as physicians, how do we know if this drug is working in this particular patient, particularly because some patients can have these late benefits, as we showed with the patient with the liver lesions that got worse before they got better. So how do we really know? There are a number of studies that are still being conducted now, looking at different imaging modalities that might help tease out whether or not certain patients might have a response to immune therapy versus others. There are other studies that we're doing looking at the blood of patients to see if the blood can show signs of immune system activation in these particular patients that might be a sign to correlate with the ultimate expected outcomes of these drugs. So we're trying to do more research, and this is where the research area is very important for us to see what markers in the blood are important to show that the immune system has been activated in certain patients, because CAT scans only give us one particular picture, and it's really hard. But beyond all these research immune monitoring type strategies and beyond these different imaging modalities that are being investigated, sometimes patients just may say that they're just feeling well and feeling better. And that's probably the most important signal to say, if a patient is feeling well and their CAT scan shows a little area of new something or some growth of one particular area, if they're feeling well, it may be worth continuing a bit longer to see really what's happening in case one of these late responses is happening. But keeping in mind that unfortunately most patients don't have that late response, still people do need another treatment after apparent progression.
And on that topic, actually, that leads right into my next question. When we saw in your charts that a significant percentage of patients have what's kind of called the long tail, meaning they remain to have, or they have durable responses to the immunotherapy, their disease becomes stable, or they have a complete response, and they remain with no evidence of disease many months and even years out after treatment. But what is the option for the patient who does receive immunotherapy, responds for a time, but then unfortunately the cancer finds a way to outsmart that response? What options are available to patients at that?
Right, so for people that have initial benefit to immune therapies, we do acknowledge that there are a group of patients that have that long-term benefit, as shown on these long-term Ipilimumab slides with that flattening of the curve. But unfortunately, we know that even though patients can have initial benefit to these immune therapies, some do eventually have regrowth of their tumors or other areas that need to be treated again. At least with Ipilimumab, Ipilimumab is given for 4 doses. If patients have had an initial benefit with that treatment and then and good tolerance with side effects, they can actually be retreated with Ipilimumab later on down the line, at least 6 months after their initial treatment course. So repeating immune therapy courses like Ipilimumab may be something that could be considered in certain patients. Pd1, we know less about what to do long-term for patients that have that benefit and that need another treatment subsequently. But clearly we know patients that progress on Ipilimumab can change to PD1 and have a benefit, and vice versa. Patients that have had PD1 approaches that then need a benefit later can get a benefit from Ipilimumab.
All right, thank you very much. Unfortunately, that's all the time we have for today, Dr. Postow. That was a wonderful presentation, and I hope it was helpful to the oncologists who are watching this, that it serves as a good introduction if you're not already familiar with many of the advances happening now in cancer treatment thanks to breakthrough immunotherapies, or if you are familiar with immunotherapy, that you found this valuable as well. I'd like to let everyone know that we do have a series of other webinars that are coming up on June 16th. We have Jeffrey Weber doing How the Immune System Sees and Destroys Tumors, David Reardon on June 23rd, Aiming the Immune System at Brain Cancer, and Dr. Jed Walchuk on June 25th will give us, I think, what is a very nice overview of what we should expect to see within the next 5 years. Given the tremendous rate of advance that we've seen in just the past couple years, we can only imagine what exciting developments we'll see in the next 5 years to come. All of these webinars, as I mentioned earlier, are available at cancerresearch.org/webinars. Also, June 12th, which is this Friday, we're whiting out cancer, and white represents the potential of immunotherapy to conquer all forms of cancer, so it's all the awareness colors combined. And we wear white on June 12th, and we encourage you to share a photo of yourself wearing white with your colleagues or friends using the hashtag #WhiteOutCancer, and we'll be following that on June 12th and hope to share your photos with our friends as well. And if you are, as an oncologist, if your patients are looking for more information about immunotherapy, some of the things that Dr. Postow discussed today, as well as other forms of immunotherapy that are available, you can refer them to our patient and caregiver website, theanswertocancer.org. The site features not only information about immunotherapies that are available, both FDA approved and in development, but also features stories of survival from patients with multiple types of cancers, sharing how immunotherapy helped save their lives or certainly improved their state of health. And with that, I'd like to let you know just after this, you will receive a survey right after we close, and we'd appreciate if you could respond to that. And also, we will be sending you a link to a downloadable document that will provide a brief overview of immuno-oncology or immunotherapy that you can share with your patients. So thank you again, Dr. Postow, for joining us today, taking time out of your busy schedule, and I thank all of those who are watching the webinar both live and available later on the CRI website and on our YouTube channel. With that, I thank you all very much. Bye-bye.